Cancer, I mean, as Fiona said, used to be an incurable disease with rising incidence and mortality, but now mortality rates are declining, and therefore we have a rise in cancer survivors, in the number of cancer survivors. So that's increased from the 1960s of 38% to over 80%. Now, it's important to note that some tumour streams are obviously not as good as other tumour streams in survivorship. So that opens up a really new area of cancer survivorship as a chronic disease these days. And we have a role as allied health practitioners, as medical health practitioners, in supporting and finding obviously new areas of cures and things, perhaps not us specifically, but supporting those who do, or, as I might talk about later, whether we see exercise as medicine. So is exercise a treatment for cancer? So there are different treatments for cancer, as you know, I'm sure. There's surgical options, chemo options, radiotherapy and molecular targeted therapy now, or a combination of surgery and chemotherapy and radiotherapy. All of those treatments have side effects, though, for the person. So the choice of treatment obviously will depend on the type of the cancer stage. So cancer staging is really important, the location of the tumour, and also the individual's pre-morbid states. So how many comorbidities they have, how frail they are, or how healthy and fit they are. And sometimes those things will actually affect the choice of treatment for a patient. So if you're looking then at side effects from these treatments, you can see that, I can see if I can do this. So from the cancer itself and side effects from treatment, depression, anxiety, distress, pain, sleeplessness. They're certainly in breast cancer, swollen arms and so forth from lymphedema, nausea, vomiting, diarrhoea, loss of appetite, as most of us know from chemotherapy, hair loss and skin changes, muscle atrophy and muscle weakness and wasting, exercise intolerance and a fatigue that's unremitting to rest. So it's a different type of fatigue, and obviously cough and shortness of breath in the respiratory system, and it will depend where the cancer is, what the treatment is, but they're the types of side effects that we see in cancer survivors. Okay, cancer cachexia, just a little bit more on that. It's a multifactorial syndrome that defines loss of skeletal muscle mass with or without loss of fat, and it can't be fully reversed with normal nutritional support. So there's a big role for dietetics. While I might be talking a lot about exercise because I'm a physiotherapist, there's a role for lots of allied health people, but dietetics specifically in the role of supporting nutrition to support protein, to support muscle mass and muscle strength in these patients. So clinically, cancer cachexia presents as a combination of anorexia, alterations of muscle protein, loss of weight and lots of fatigue. It's a whole syndrome. And so within that syndrome, dietetics, physio, social work and psychology, just to name some of the areas of allied health, are really important in the cancer journey for patients with cancer cachexia, which is quite a lot of the patients who are on chemotherapy and radiotherapy or have tumours that are really not very responsive to treatment. Okay, so just moving then to exercise capacity. So why do patients who have cancer, who are on treatment and then after treatment have poorer exercise capacity? And the reasons are here that the treatment can affect exercise capacity. So there's an increase in fatigue, there's nausea and vomiting, which stops you moving around and doing things. There's deconditioning, so it's a cycle. So the less you do, the less you can do. So the more fatigue you have, the less you do, the less you can do. Most people with cancer are older, and a lot of people have comorbid disease. So even if it's just osteoarthritis of the knees, that can affect a person's ability to walk and move around, and that can then lead into the deconditioning cycle as well. So there are obviously specific aspects of disease pathology as well that feed into the poor exercise capacity. So this is a complicated diagram, I know, but it's a complicated area. So we've got, you know, patient-reported outcomes of reduced health-related quality of life, anxiety and depression, and deconditioning, and all of the things that feed into them. So symptoms, unremitting fatigue, treatment side effects, diminished physical activity, comorbidities if there's smoking, and particularly in lung cancer, obviously, all feed in to this cycle of affecting patient-reported outcomes, which are extremely important and mostly related to reducing function and reduced health-related quality of life. So there've been obviously quite a bit of research around this area, and this research was from the UK, and they surveyed thousands of people and found that less than 25% met physical activity guidelines suggested for age. Nearly half experienced significant fatigue, and half had existing chronic disease comorbidity. So you can see that, you know, these are areas that these people can be supported in through their cancer journey. So in lung cancer, which is probably my specific area of expertise, there is, for example, a significant disease burden, more so than most other cancers. Very complex symptom clusters with shortness of breath, with pain, and anxiety and depression and so forth. They have greater psychological, patients with lung cancer have greater psychological distress than in all other cancers, and increased depression compared with other tumour sites. And part of the reason around this is that the survival statistics for individuals with lung cancer are still poor. So around 14%, 5-year survival still. That has improved over the years, but it's nothing like the survival of blood-borne cancers, for example. And so you can understand, you know, perhaps why they might be more depressed and anxious. There's lots and lots of research now being undertaken, and has really been for the last 5 years. This is an example of some of it, and you can see the words that I've circled here, exercise interventions and how they might affect quality of life, exercise, how it might improve fatigue, how it might improve depressive symptoms, functional capacity and physical function and muscle strength. So lots of research is being undertaken and has been undertaken to suggest that multimodal input, including exercise, can actually impact the really important outcomes for patients. So exercise and cancer. So exercise is associated with improved survival, and I'll go into that a little bit more. So for people, and that's in breast and colon cancer, for people who walk more than 3 hours at a moderate pace, so moderate intensity, 3 kilometres an hour. Exercise can improve fitness and function. I mean, we all know that. I mean, we need to walk and go to the gym and meet the exercise requirements as well. You probably do that just running around the hospital treating patients, whereas I sit at my desk all day, so I actually have to make an effort to do that. Exercise can improve fatigue, and I know that sounds like counterintuitive, but this fatigue is different to fatigue when you've, you know, been for a 1-hour run. And so education around this for patients about how, yes, we know you're tired, but if you actually get up and go and do something, you might be less tired, is really important. Health-related quality of life is a difficult measure when you're measuring patients' quality of life, and it tends to not appear to respond well to a lot of input. And one of the reasons around that is that people adjust their perceptions and expectations. So if you measure quality of life at diagnosis and then you measure it at 6 months, that patient's adjusted to what's happened to them in life and doesn't have as higher expectations. So you actually don't get a big difference necessarily in the quality of life, whereas it's really quite much easier to measure function. But there have been papers where exercise and multimodality input has improved quality of life, and certainly depression and anxiety and mood associated with that. So there's a lot of people use physical activity and exercise interchangeably as words, but indeed they're different. So when I talk about physical activity, what I'm talking about is just moving the muscles that results in energy expenditure. Okay, so physical activity is about moving. However, exercise is a subset of physical activity that's more planned, structured, specific, has specific objectives. So they are quite different. And if you look up the World Health Organization definitions of physical activity, exercise and rehabilitation, so exercise, again, is a subset of rehabilitation. And we do tend to, certainly in other areas that I work in, I work a lot in the critical care survivorship space as well. People use mobility, physical activity and exercise and rehabilitation all as the same thing, and I don't believe that they are the same thing. So we study them separately. So rehabilitation is much more multidisciplinary with specific goals set for the patient. But improving physical activity is just getting the patient moving and walking, or swimming or playing golf or doing something like that. But it is quite specific, and I just wanted to sort of make that a little bit specific to a multidisciplinary audience, because I think physical activity is something we can all push, but prescribing exercise and rehabilitation should be prescribed by a health professional. So physical activity is, we can read the guidelines and we know that we should be walking 30 minutes a day, 150 minutes a week to meet our baseline guidelines, or 10,000 steps as is published. But exercise and rehab are quite different. Okay, but physical activity has been shown in research to reduce or improve survival, reduce mortality. Higher levels of physical activity appear to be protective against colon, breast, pancreatic, endometrial and prostate cancer. That's where the research to date, it's early research. No, we don't have 10 to 20 years of research to say, okay, we can definitively say you need to exercise because you will improve your survival by 10%, 20%. These are earlier days, but there are papers that show improved survival in those cancer tumour streams. They are also papers that show that there's a 40 to 50% risk reduction in the development of colorectal cancer, and a 40% risk reduction for the development of breast cancer associated with increased levels of physical activity. And certainly in the prostate cancer, for men with prostate cancer who are on surveillance therapy, for example, increasing physical activity, which can be associated with reducing obesity, reducing weight and so forth, has been shown to be a positive thing to do that extends the life of surveillance before definitive treatment. So there's quite a lot of work in a lot of tumour streams that obviously I can't go into in specific detail today, that shows that physical activity, just improving what the patient's doing at an activity level, can actually impact survival. So just before I show you the next graph, I just wanted to talk about metabolic equivalents, or METs. I know that the nutrition people will know about them, the physios will know about them, I'm not sure about others. So one metabolic equivalent is just resting. So if you're just sitting resting, you're really not, that's just basal metabolic rate. That's one metabolic equivalent. So what a lot of the papers do now is talk about METs per hour, so MET hours, so METs and physical activity. So if you're walking slowly, which is less than 3 kilometres an hour, that's about equivalent to about 2 MET hours of exercise. If you're running, it's equivalent to 13 Met hours. And if you're walking briskly, which is what the recommended guidelines suggest, moderately, that's sort of 3 Met hours. So if you are walking for 7 hours a week in total, which is an hour a day, you've done 21 Met hours, which is quite a lot. What the recommendation is half that, isn't it? So it's about 10 or 11 Met hours. But for those of you who run around the hospital, you would be doing that anyway, I'm sure, because I know I used to when I was a physio at the Austin. So that's Met. So this graph that I'm putting up now looks a bit complicated. It's a survival curve, a Kaplan-Meier survival curve. And what I really want you to look at here is that this is time in years across the x-axis. And this is whether the patients are alive or not on the y-axis. The red line, which comes down pretty steeply here, is less than 3 Met hours. So these people are doing mild, exercise, not even moderate exercise. The next blue line that isn't as bad, so they're not dying as quickly, is moderate exercise. And this line up here is quite a lot of exercise, so 18 Met hours. So that's about 6 hours a week of walking briskly, moderately. Now this is for patients with colorectal cancer. So what you're seeing here is that there's a dose dependency around how you can impact survival in cancer. So the more, this is in colorectal cancer, the more the patient does, the better, basically. Now, not all patients can achieve that, and people who work haven't got time probably necessarily to achieve that unless you do it all on the weekends. But you can see that there's a dose-dependent relationship, so it's really important for people to walk moderately, not slowly, for them. However, on the other side of that, there's certainly thought that if you can actually move someone from sitting in front of a television from 10 hours a day just to do something, that will still have some benefit. So a huge range, but there is a dose dependency around how much physical activity in helping survival, improving survival. Similarly, again, really early days in lung cancer, so peak oxygen consumption's measured with a cardiopulmonary exercise test, with the bike and that big mask and the VO2, and people have to cycle or run on a treadmill and exercise to maximum till they just about feel as if they're going to vomit. So that's where you get peak oxygen consumption from. But Lee Jones has done a lot of work. He's in the US. He's an exercise physiologist, and he's done a lot of work, and he's found that in, I think it was about 400 patients, which isn't very many for this sort of work, that for every 1 mil per kilo per minute, so that's how you measure oxygen consumption, survival in lung cancer is increased by 7%. So again, this is adding to the literature, but this time in lung cancer. And you can see that this was only in 2010, this was published. So it's pretty early days yet. Those of you who understand the 6-minute walking distance better, so how far you can walk in 6 minutes, he also found that for people who can walk more than 400 metres, that's associated with greater survival. I think it was 50 metres actually, exactly. So if you can walk 50 metres, the survival's improved again by around 7%. So 6-minute walk and VO2 peak or peak oxygen consumption are sort of measuring the same thing. 6-minute walk is a field walking test equivalent of the gold standard test. So in non-small cell lung cancer, again, some survival benefits of improving functional capacity and exercise capacity. So in lung cancer, again, I'm sort of coming back to that just as examples because it is my area or my group's area. I've got quite a few, I've got a postdoc and two research high degree students doing work specifically doing research in this area, and one of them is here at St V's. It's Anna Tierney. Oh, Anna Shukla, sorry. since she was married. So what's been looked at now in lung cancer, as well as in other areas, is exercise before surgery, as well as exercise during and after treatment, so post-operative or during chemotherapy and radiotherapy, and also exercise in advanced disease as well. And so currently there are 5 randomised controlled trials looking at prehabilitation, which is exercise before, 3 looking at the post-operative rehabilitation of these patients, and 2 looking at rehabilitation of patients with advanced disease. And we're currently also looking at rehabilitation of patients with advanced disease in an NHMRC funded trial that we're using Royal Melbourne, Austin and Peter Mac for those patients. So you can see that there's a building up of evidence looking at rehabilitation. And this is specifically rehab, so this is multidisciplinary. So for our trial, for example, it involves physios, nurses, regarding symptom management and psychology as well. So these are multidisciplinary. Okay, so what is prehabilitation? It's a great word. The computer corrects it every time you write it to rehabilitation. So it's defined as a process on a continuum that occurs between cancer diagnosis and treatment that actually aims to improve the patient's functional capacity. And sometimes this can help them to withstand the cancer treatment. So, for example, in lung cancer, sometimes prehabilitation can actually mean to improve the patient's function enough to be able to have the surgery, not just withstand it. Because if the patients aren't functional enough, are too frail, don't have good enough functional capacity, then they can't be operated on. But if you can improve that in the very short time that you have before lung cancer surgery, so between 2 and 4 weeks is all you would have, because obviously surgery is not stopped. That's the most important thing. If you can improve function, some people can go on to have surgery when they might not have. So prehab includes a bundle of care. It's not just about the exercise, it's about smoking cessation, diet optimisation, psychosocial support and exercise, of course, that identify impairments and obviously provide targets. So it's education as well about all of those things. So again, multidisciplinary. This is a really interesting statement from the Society of Anaesthetists from the United Kingdom. So they just published last year one of the top 10 from a list of 92 most important questions needing to be addressed in perioperative medicine, identified in this big survey that included patients. How can preoperative exercise and fitness training improve outcomes after surgery? So it's a really important question. It's a question that we have asked in and applied for a multidisciplinary project with this round of the NHMRC. None of us hold out hope with a 12% success rate at NHMRC, but you never know. So that will be, so we're looking at multidisciplinary prehabilitation in patients presenting for lung cancer. So we hope that gets up, and that's with Gavin Wright from here as well. So that will be undertaken at St Vincent's as well, if we get the money. Okay, so what you do in prehabilitation from an exercise point of view is you've only got 2 to 4 weeks. So you have to really ramp up the exercise. 1 or 2 days is not going to cut it. So you need to be really lots and lots of exercise. So probably 4 days a week of exercise, probably aerobic exercise, so bike, walking, treadmill, those sorts of things, as well as resistance exercise because of the loss of muscle mass and the loss of the cachexia syndrome. So, but nobody really knows quite what is the best exercise. So most people at this time are doing a combination of aerobic and resistance. And that can be supervised outpatient or individual, and indeed there are some home-based programs as well that have been reported. Sometimes they have to be a combination of both. So St Vincent's, for example, have a lot of patients coming from the country, and so do Peter Mac. So you can't actually do everything as an outpatient. So you really have to set up outpatient and home-based exercise for these patients. So what's been shown in the prehab literature to date, mostly small trials, small numbers, up to 30 patients, so not powered for the outcomes that they're measuring. But there's been shown to be an increase in the functional capacity, this is preoperative, a reduction in post-op pulmonary complications, and a reduced hospital length of stay, which would be, not just about patients, hospital administrators would be obviously happy with that. An improvement in muscle strength, and again, health-related quality of life, very hard to measure, but the results haven't been significant necessarily on those. We've actually just finished a large trial in Tasmania and in New Zealand looking at post-op pulmonary complications in a population of 440 patients with abdominal surgery. This is a PhD student of ours at the university. And we found that preoperative education reduced the number of post-op pulmonary complications in that group. But what's the most interesting part of this is that it's also looking like mortality has been reduced at 12 months just by reducing pulmonary complications from preoperative education. So hopefully we'll be publishing that in the next 6 months. But most of those patients had colorectal cancer, which is why I mention it. So there's a lot you can do from a prehabilitation space that's about education as well as about exercise for patients. And the other thing that we found we looked at some qualitative evidence in 30 of those patients and found that they all remembered what they'd been told and all did the exercises that they needed to do. So we think that's why they're really empowered, the patient's empowered to look after themselves post-operatively. Why we got such good results. That's the only thing we can, really think of. But that's colorectal cancer. So in prehabilitation, in this space, so Catherine Granger, who is a postdoc, currently in our department, has a preoperative exercise training for patients with non-small cell lung cancer, Cochrane review protocol, working with another physio from Western Australia. So more research is happening in the prehabilitation space. This is what Anna's doing here at St Vincent's with Gavin, and looking at prehabilitation and see if we can improve outcomes in patients with lung cancer. Okay, so no, that's prehab. So what about rehab? Okay, we've done quite a bit of work in the area in lung cancer. There's been quite a lot of work and still some current work in colorectal cancer. There's a big study called the Challenge study being run out of Canada, and I don't know whether St Vincent's is part of that study. And, it's huge. They've got so many sites. They must have about 10 trial managers, I think. It's a very, very big study. But recruitment's been quite difficult in colorectal cancer. Recruitment's not as hard, it doesn't appear, in lung cancer, and I think the reason is because people with lung cancer are just very happy for any sort of help at all. So we've had very few refusals in our other study, and I'll talk about. But in lung cancer, we did the first systematic review about how exercise, that Catherine led as part of her PhD, can improve lung cancer. And then we actually looked at 50 patients from diagnosis to 6 months through in lung cancer, just to see what exactly is happening with their functional capacity and so forth. And what we found, so this graph is of 6-minute walk distance in metres on the y-axis and time. So baseline is diagnosis when they were recruited, 10 weeks, which is sort of a couple of months, and then 6 months. And what we found was that and that red dotted line is what's currently the normal predicted average for patients of this age group. It's about 630 metres on average, because we just took the average. And what we did find is that the 6-minute walk distance reduced over the 6 months from diagnosis through treatment, no intervention in this group. But what was really interesting is how low functional exercise capacity measured using the 6-minute walk was at diagnosis. So these patients start off at diagnosis low and then actually reduce over time. And you can see the same track for changes in muscle strength, which we measured using a dynamometer, where you measure in kilograms the strength of the quadriceps muscle in this instance, and you can see the same decline over time. So what we established is that, again, at diagnosis, these patients really are needing something. So that really supports the prehabilitation aspect. But then over time, to see if we can actually even just keep that line straight across there over 6 months, not necessarily increase it, but just keep it level, would be a good thing to do. So rehabilitation afterwards. So these data really supported, certainly in lung cancer, what our next steps were in our research program. So exercise after treatment in lung cancer has been described between 4 and 14 weeks, and it depends where you are. So it takes a pulmonary rehabilitation type of model, which is 6 to 8 weeks, 8 weeks preferably. 12 weeks is probably ideal, but most hospitals don't have the resources to have 12-week exercise programs. They do in the US quite a bit, but that's a user pays system. So they often have 12 weeks, but say 4 to 14 weeks. Aerobic, resistance, combination, supervised, inpatient, outpatient, home-based, all of those different settings have been published. And the results are, again, that functional exercise capacity and strength are increased, fatigue is reduced, anxiety and depression symptoms are reduced, again, inconsistent results in quality of life, and RFTs are respiratory function tests. So I personally don't think that is a reasonable outcome measure, because they're going to be very hard to change with anything from an allied health point of view. Okay, so we also know, and this is a really nice, small, sort of elegant study, how you can increase, with intervention of resistance exercise, you can actually show that you can increase muscle strength. So this is 13 weeks post-diagnosis, again here, and this is muscle cross-sectional area. Sorry, I hope you can hear me, measured with an ultrasound. And what you can see is this dotted line here is the resistance training group. And what you can see is that you can actually, with resistance training, get an improvement in the cross-sectional area of the muscle with diagnostic ultrasound. So we know it works. So this is a really nice little mechanistic study to show that when we're training muscles, we know it works. This one is actually showing quadriceps force. So quadriceps force on the y-axis here, and again, different time points of measurement. But again, this shows you can actually improve in the intervention group quadriceps force as well as cross-sectional area with just resistance training. So that really is aiming to, and they did actually, so nutrition is a confounding variable in this. So if you have to make sure that the patients are all having optimal nutrition if you're just wanting to measure muscle strength. So that was something that they did in this paper, but it is important to do that in papers. But we know that we can actually improve muscle strength, improve cancer cachexia. This is a systematic review, again, evidence showing, if you look at this forest plot, so the forest plot favours control to the left here and favours exercise or treatment here. These are 3 different randomised controlled trials that looked at post-exercise in lung cancer after surgery, and that's the mean there and some confidence intervals. Now, they should all be, and that's the overall mean, so it should be on this side of the line, favouring exercise and not touching the line for a significant result. That's how you read these. So that's for the 6-minute walk test in metres, so that we can improve functional exercise capacity. And functional exercise capacity is what you need to perform activities of daily living. So it's a really important measure. So it has been correlated with how people function at home in their own homes. And this is the same one, but looking at health-related quality of life. And if you have a look again at this, you can see that the average here sits on that line. So there's no significant difference in health-related quality of life with a post-operative program in lung cancer. And that looks pretty similar in a lot of the different cancers, and for the reason I explained earlier. Just again, some research, and I thought it was really important to say that nutrition and physical activity guidelines have been already developed for patients with cancer, and indeed they actually look very similar to activity guidelines for you and I. So there's actually no difference. So there are 150 minutes a week of moderate exercise, or 75 minutes of vigorous intensity exercise, and that patients should, or people should, do some muscle strengthening. So similarly, as you age, you lose muscle mass. So as people age, they should also do muscle strengthening exercises as well. And most cancer survivors are in the higher age group. So it's really no different to, you know, what I should be doing every week, even if I had cancer. So that's our aim, is to really get people with cancer more motivated to exercise. And again, lots of different, just to show you how much evidence there is already. You know, there's meta-analyses and systematic reviews are supposedly the highest level of evidence. They have their own problems, though. So if they're not working with good quality papers, then the quality of the systematic review and meta-analysis isn't that good either. But you can see that there's been lots and lots of work in this area and lots of evidence in this area. When we looked at physical activity in that group of 50 patients with a patient-reported outcome called the PACE, don't have to worry about what that is, we found again that patients with cancer, compared to a healthy group we measured in the same sort of area, were much lower in how much physical activity they were undertaking. Patients do have preferences around exercise, and they have been asked, you know, 175, what exercise they would like to do. Walking was highest on the list. I think people find walking the dog, walking with other people really important. Going to a cancer gym, some didn't really mind. You know, again, I've talked about aerobic and resistance exercises. That's what we normally include, but we don't really know. We know, like, for example, in diabetes, that resistance exercise is really important, probably more important, but we don't know. In cancer, it may be equally important, but we haven't looked at that yet. But there is a really good paper on a framework for exercise prescription, again, led by Lee Jones, Lee Jones's group, an exercise physiologist. There's work, so you might ask, should we be doing prehab or rehab, or should we do both? We don't know. They're both important. They both improve the patient. This protocol paper, I just don't know how they're going to do this research. It looks so complicated, but they're going to try and work out whether prehab's better than rehab in a nutshell, but nobody's done it yet. These are just different measures that probably are more interesting to the physios that I can go through, but different ways that people are measuring. And again, measurement is really important in getting the evidence. So it's important for the evidence in research, but it's also important for clinicians, because you need to measure effects of your intervention. So you need to have something that's feasible, that's cheap, that you can do in the gym or the bedside. So it's really important choosing your measure and measuring the patient as they go along as a clinician, as well as it's important for researchers. I won't talk about that. I won't talk about, I've got a few slides on bone marrow transplants, just to say it's not all about lung cancer, just because that's my area. We've done some work in colorectal cancer as well. But I just wanted to sort of leave you with this, that promoting exercise after cancer is easier said than done. And I know that you will know that, because, you know, if you go to your dietitian and they say, you need to do this, do you do it? If you go to your physio, you need to do these exercises, do you do it? It's really, really difficult to promote exercise. And so this is where psychology comes in. So behaviour change, where is this patient on the behaviour change line, okay? So for optimal uptake of exercise, you have to think about what the patient wants, you have to do individualised goal setting, and as I said before, small gains in behaviour change, just moving them from the couch to walking 10 minutes a day might be important, but psychology is important. It's, you know, the patients won't do anything unless you can look at their behaviour as well. General advice for patients to keep active. Walking is important. Walk with people, walk with the dog. It's great, getting out in a group, walking with friends. Be aware of exercise intensity, so walking and talking is important. Puffing's okay, providing you can still talk to someone. Obviously wearing appropriate footwear and clothing, drinking, and don't exercise in extremes of temperature. So that is advice that all of you can give to anyone that you know, any patients, any friends who have cancer. It's a really important advice. It's important for their well-being, and it can improve all of their symptoms. I just wanted to leave you with, and you could have these slides, that exercise is medicine, and there's certainly a push around what the effects of exercise are. This is a really complicated graph from Daniel Galvao, who actually, and Rob Newton, who was on the Catalyst program around prostate cancer. But really what it's saying is that exercise can modulate the immune system by reducing inflammatory markers in the blood. It can do other things, testosterone change in tumour vascularisation, and lots of other really sort of more cellular level things. So there's a lot of thought now that by exercising and reducing your inflammation, you might actually be able to impact the tumour, not just being a supportive care environment and, you know, continuing to support the patient, but it might actually impact the tumour. That's all I really wanted to say, except that we're just doing this Tiger trial, which is actually looking at exercise in the home in patients with more advanced lung cancer. And we've recruited 60 patients into this trial. So we're hoping that this multidisciplinary approach will help patients. So this is symptom management, nurses, psychologists and physios all working together for these patients. Thank you.